Summit. And today I'm really excited to speak to Dr. Priyumvada Naik. Dr. Naik is actually the niece of my classmate from IIT. And
cousin.
Oh, you're the cousin. Okay, I thought you were the niece.
First
okay.
cousin. First cousin.
All right. And I've known her cousin since the age of 16. So we go a long way back. And when
he introduced us because he said that I harassed him about going vegan, just like you do.
Right. So we have something very much in common there. But when I got to know her, I realized that this is a superwoman that we are talking to. She's amazing. If you look at her bio, I think you will see that she's done so much. You wonder when she goes to sleep. She's triple board certified in pulmonary medicine, critical care medicine, and lifestyle medicine. And so if you want to know about COVID-19 and the symptoms of COVID-19 and how to mitigate them, how to treat them, this is the right person to talk to. So I asked her if she would come on and help us understand what's going on with this disease, why it is serious, and what we should be doing about it. And she readily agreed. So I'm grateful to her for taking this on. Thank you so much for joining us, Dr. Naik.
Thanks for having me.
Yes, it's a pleasure to have you with us. So I know you have prepared something. You have prepared a presentation. So perhaps, do you want to start with that, or do you want to?
Yeah, I think, I'm hoping that, I want to be able to answer everyone's questions, but I'm hoping that if I go through some basics in a somewhat organized fashion, it might help to actually start to answer questions along the way. So can I get the slides shared to everyone?
Wonderful.
And I need to figure out, will I be able to see which slides we're on and where?
Yes, you will.
Okay. So Deborah's going to share them. There we go. Perfect. Okay. So if you'll put it in slide view. Perfect. Okay. So as Sailesh said, hi everyone. My name is Priyumvada Naik. I am board certified in pulmonary medicine, critical care medicine, and lifestyle medicine. So for folks that don't know, my background is internal medicine. I just let that board certification lapse because I don't need it, and nobody really needs to be quadruple board certified. So it doesn't necessarily help me. The lifestyle medicine is the most recent one. I've been vegan for 9 years, and I've spent the last 8 years counseling my patients in the ICU and in clinics on how to go plant-based to really help folks completely reverse chronic diseases like heart disease and type 2 diabetes and those sorts of things. But my first and initial love is pulmonary and critical care. So what I wanted to do is I want to start out with a little bit of some of the basics of COVID-19. We all know it's a respiratory virus. It is an RNA-based virus. And that's important because it's why we've started looking at certain therapies, which I'll talk about in a few minutes. And the really scary thing about this is, unlike many other viral illnesses, we're seeing very rapid progression of lung disease, which we're not seeing with other typical viral illnesses that we might see. We're also not seeing it with other coronaviruses. So you're going to hear me use two terms, COVID-19, which refers to the actual virus, and you're going to hear me use the term SARS-CoV-2. And that actually refers to the clinical syndrome that occurs with COVID-19. So if I can go to the next slide. So what I want to do is I want to start out with just talking a little bit about the myths, because there is a lot of misinformation out there. So next. Everyone is saying this is just like the flu. Well, there are multiple reasons why this is not like the flu. So if you'll bear with me, I'm going to go through them. So first and foremost, it's not like the flu because unlike the flu, we don't have a vaccine for this. So we know that the flu vaccine is not perfect. But when we get the flu vaccine, we actually are able to mitigate the risk of getting the flu. We're able to mitigate the symptoms of the flu if we get the flu, meaning we're going to have a milder course and it's going to be a shorter course. So that's one way it's not like it. Another way that it's not like it is there is no proven therapy for COVID-19. We have 5 different antivirals that we can use for the flu. So if you happen to be someone who is resistant to Tamiflu, there are 4 other options that we have for you. The timing of this disease is also very different. So most people who get the flu do not progress to ARDS, which I'm going to talk about in a few minutes. And unfortunately, we're seeing a very large proportion of patients who become symptomatic with COVID-19 going on to developing ARDS, which is a very debilitating disease. The other thing that's unusual about this, and this is the thing that I think people aren't understanding, but this goes to the heart of why we need people to socially isolate. When we have a flu season, it goes from maybe late September, early October through to March or April. And so on average, we're getting a slow, steady trickle of patients. In December and January, hospitals tend to get very full. So a lot of times my ICU might be on diversion because my ICU is full. And a lot of that is related to flu illness. But it's also related to the fact that we have a lot of common respiratory ailments like COPD and asthma in America. And so in the winter, when people are passing even just minor colds around, they tend to get more disease. And so then they end up in my ICU. But when you're spreading it out over time, we can handle that in healthcare. What's happening with COVID-19 is we're just getting a massive influx of patients very quickly, very suddenly, overwhelming our ICUs. So when your ICU beds are full, where do you send your patients who need critical care monitoring? When you run out of ventilators, what are you supposed to do? And these are real things that we're seeing happen. Now, to be clear, this happens every once in a while just during the flu. So there's usually about a week in December and a week in January where everyone's really stressed out because there's no beds, there's barely any ventilators, there may not be any ventilators. And that's when we don't have a pandemic. So now we're adding pandemic stresses to that, and we're just not equipped to do that. And we can talk about why we're not and all of those things. That's maybe for another time, but that's just the fact of where we are in healthcare. And this is not unique to America. This is globally the case. Another issue is mortality. So we don't yet know what the mortality in the States is going to be. We certainly know that the mortality in certain areas of China have been as high as 8%. Our average, we're guessing, is going to be somewhere in the 2 to 4% range. And the flu from year to year is going to be between 0.1 and 0.9% mortality. So that's a huge difference. Another difference is the infectivity. So another way of looking at it is you might hear the term R naught. So the R naught for the flu is usually around 1 or 2. The R naught for this is around 2 to 4. But here's the thing about the R naught. That's a very modifiable factor. How infectious this becomes is directly dependent on our behavior, which is why we're asking people to isolate. But these are all ways that this is not like the flu. Another way this is not like the flu is when someone has the flu and they develop ARDS, I might end up intubating them. It's usually a gradual process. They slowly over a couple days get worse, and then they ultimately end up needing a ventilator. What's happening with COVID-19 is people are showing up to the ER short of breath, and in 6 hours, they're crashing and on the ventilator on life support. And then when they're on the ventilator, on average, you're on the ventilator with the flu for maybe 5 to 7 days. Currently, the average length of stay for COVID-19 on a ventilator is 22 days. So you now have an ICU where for an entire month, you're running ventilators. And that has really debilitating effects on the actual patients as well. So so those are just some of the ways that this is not like the flu. So next. So I'm hearing most people die from heart attack and stroke. This isn't really that big a deal. But again, when people are dying from heart disease and stroke, they're dying over time, and our healthcare systems can handle this. We have the ability to cath someone and send them home. When my dad had his cardiac arrest at the age of 45, he was in the hospital for a week and a half. That was that was decades ago. Now someone might have a cardiac arrest, we fix them, we put in their stent, or we send them to bypass, and they're out within a week. They're not in the hospital for 22 days. So next. This is because of Chinese wet markets. So this is something I'm hearing a lot of. And yes, technically this probably originated in Chinese wet markets, but make no mistake, this pandemic exists not because of Chinese wet markets, it exists because of non-veganism. It exists because we believe that animals are ours to commodify. So swine flu did not occur in Chinese wet markets. Swine flu occurred in the US. It started in the US and it spread globally, and hundreds of thousands of people died from it. So this is not an unexpected thing if you understand how pandemics arise. And I know, Silas, that you're going to have Aisha Akhtar come on later, and I'm super excited to hear her speak about this. She's literally written the book on this. Next. This is a disease of the old. So I'm hearing that a lot. So we hear a lot of, look, if you're young, you should socially isolate just because you can hurt other people. The reality is you can be sick with this. So the last CDC morbidity and mortality weekly report that came out up to date as of March 16th looked at survival and looked at hospitalizations. And what they found, and I'm sorry, you're going to see me looking at my notes because I didn't memorize the numbers. What they found is that 20% of all hospital patients are aged 20 to 44, and 18% are aged 40 to 54. So almost 40% of admissions in America, unlike in Italy and some other countries, are in what we would consider young people. And not all of them have pre-existing conditions. So this is not a disease of the old. And as we go through this, I hope you'll understand that if you get hospitalized and you have ARDS and you survive, it's not a situation where you go home and everything's great. There is real permanent disability that occurs in survivors of ARDS. Okay,
explain
next.
what ARDS is.
Yeah, well, so I've got more slides than you'll ever want to know about ARDS, and we'll go over that in just a few minutes. So we need to wear N95 masks. So this is just not true. The people who need to wear N95 masks are the people who are in a high-risk situation, nurses, respiratory therapists, physicians, who are in contact every day with multiple patients who have a high infective burden with COVID. So when you wear an N95 mask, if you have N95 masks, please, I'm begging you, donate them to your local hospitals because they need them. When people wear masks now, and you can go to the next, thing as well, where, people keep saying masks need to be worn by everyone. When this whole thing started out, you heard multiple physicians say, no, people don't need to wear masks. The reality is when you wear a mask, you're protecting other people from you. You're not protecting yourself. If you wear an N95 mask, you are, but N95 masks need to be fitted formally. I go through a yearly formal fitting where they put this big thing on me and then they try different masks and then they make me inhale noxious stuff to see what fits me. You have to learn how to put an N95 mask on properly and take it off properly. The average person takes off their N95 mask and immediately contaminates themselves when they do. So this is not a helpful thing for people to be wearing in the layperson world. Right now, the CDC is contemplating saying we should just make everybody wear masks. And frankly, the reason they're doing that is they've just basically put up their hands and said, all right, fine. No one is listening to us. No one is self-isolating. So if everyone's going to go out and do what they want to do, the best protection is for everyone to wear a mask so we can all protect ourselves from each other. But in a perfect world, we wouldn't have done that. We would have isolated and locked down immediately and nipped this in the bud. Okay, next. Next. This was created in a lab. I'm seeing that a lot. So if you guys want to Google nature.com genomic sequence COVID-19, you can see the article that shows that this is very clearly a wild type virus. There's no evidence that this is lab, that this is like some sort of bioterrorist act. Next. So initially there was data to suggest that droplets last in the air for 3 hours. So this is a disease that is transmitted through droplets. So breathing, coughing, sneezing, droplets come out of your mouth or out of your nose, and they'll travel about 6 feet before they're too heavy, and then they'll drop to the ground, which is why we say a greater than 6 foot distance. There is some data in a laboratory situation that you can aerosolize droplets and they'll last in the air for 3 hours. But what we're seeing in a lab doesn't necessarily mean we're seeing it in the real world when someone coughs. So there's no real evidence that we need to be worried about, oh God, did I just walk through something that 2 hours ago someone sneezed on? Next, there's a vaccine ready to go. There is not a vaccine currently. What we are seeing right now, there's two different phases of the trial. So the first phase that started last week was not an efficacy phase, it was a safety phase. So we were simply injecting people with the vaccine to make sure that there were no side effects to it. If you are interested in joining the actual vaccine trials, they're going on nationally. My colleagues at Emory are doing one now, so you can Google Emory University COVID-19 vaccine trials. My really good friend, a guy that I actually helped train, Anish Mehta, is actually the guy running the trial. It's in great hands, and so I think we're going to get some really good data from that. But there is currently not a vaccine ready for prime time. Next. There are a few great treatment options. There are not, and I will go over what we do have that are experimental and why we think they might work and which ones are working and which ones don't seem to have as much promise. Next. I'll actually have you go down one as well, so I'm going to address both of these together. Okay, so we've heard a couple different things over the past couple of weeks, and you know, I want to make sure that people understand that medicine is not the wild, wild west, but when there is a pandemic, information is coming at us fast and furious, and the stuff that we're getting from China may not necessarily translate here, and that's why we're sometimes seeing information change from day to day and week to week. So initially the WHO came out saying we need to stop using NSAIDs like aspirin, Aleve, that kind of thing, and everybody should be using Tylenol. In the States, we never really felt that the data was there, that it was strong enough to be made as a national recommendation. And then interestingly, the WHO actually removed that recommendation, and now they don't feel that way. That said, if you're nervous about using NSAIDs, you can use Tylenol as long as you don't have severe liver issues and your doctor's fine with it and you don't take any more than the prescribed amount. But if you need actual anti-inflammatory effects, there is no evidence currently that we should stop people from using NSAIDs. So the reason I wanted both of these 2 points to come up together is they're sort of related, the mechanism is sort of related. So there's also a suggestion that we might need to stop certain blood pressure medications called ACE inhibitors and ARBs, or angiotensin receptor blockers. The reason for that is quite simple. The COVID-19 virus has a spike protein that attaches to a receptor on our cells called the angiotensin converting enzyme 2 receptor, or ACE2 receptor. So the ACE2 receptor is the target of things like angiotensin converting enzyme inhibitors, ACE inhibitors, or ARBs. But what happens when we take these medicines and when we take NSAIDs is that we actually get an upregulation of the receptor on our cells. So initially the thought process was, are the people who are dying of this disease, the people who have heart disease and type 2 diabetes and hypertension, is it not so much the disease itself, but the fact that we have them commonly on these medications because they're very commonly used to protect the kidneys and the heart in these disease processes? There isn't good evidence to suggest that we should take people off these medicines. The reason I bring this up is because a lot of patients are starting to panic and they're starting to come off these medicines. And the problem is these medicines are very valuable, right? They protect your kidneys if you have type 2 diabetes from kidney failure. If you have heart failure, ACE inhibitors are shown to actually remodel the heart and improve your heart pump function. So at this time, the last thing we want to be doing is starting to have people develop worsening heart failure or worsening kidney failure and then get COVID. If at some point the evidence changes, of course, we'll be the first ones to talk about coming off these medications and transitioning, but nobody should be stopping their blood pressure medicines or transitioning to something else without talking to their personal physician. Next. So apparently there's this thing called COVID-19 parties, which is absolute insanity. The problem with this, again, is a lot of people are going, well, I'll just get it, I'll have mild symptoms, and then I'll be immune and everything's great. The reality is we do not know if you can get reinfected. We haven't been exposed to the disease long enough to know if you actually get immunity when you are infected, number one. Number two, I hope I've shown you from the statistics, there's no evidence that if you are young that you are immune to getting severe disease. So we cannot remotely say that this is good practice. This is really, really dangerous, irresponsible behavior. So don't try to get COVID-19 so that you can become immune. Okay, so now that we've gotten the myths out of the way and some of the incomplete truths, why don't we talk a little bit about symptoms and treatment options? So go to the next slide, please. Okay, so the way that we're characterizing the disease at this point is mild, severe, and critical. So with mild disease, that's about 80% of patients. Some people may not have any symptoms at all. They may have mild symptoms of a fever, cough. They may have a mild pneumonia. Interestingly, in China, for whatever reason, if they test positive for COVID-19, even if they don't have symptoms, they're doing CT scans on them. And they're finding that a large portion of patients who are positive without symptoms actually have minor changes on their CT scans. This is actually an image of a totally normal lung. And I'm putting that up there because I'm going to show you images of very abnormal lungs with SARS-CoV-2. Now, when I say that people can have CT changes with mild or minimal symptoms, you do not need a CT scan if you have mild or minimal symptoms. All that accomplishes is exposing you to unnecessary radiation and contaminating the radiology department, because it doesn't change your management. In no way is this going to affect how we treat you. The treatment is supportive care. Stay home. Do not go to your doctor. Contact your doctor via phone or via the electronic medical record system. If there is testing available in your area for mild or minimally symptomatic people, then you should get tested. Unfortunately, in the US, we have completely bungled the testing process, and so testing isn't available for everybody. The reason that testing is important is because what we want to make sure that we do is, if you are positive, then we can definitively say you need to be isolated, right? If you turn out to be negative, but you turn out to be positive for flu, well, sure, you need to be isolated, but you just need to be isolated until you get on treatment and your family and exposures are put on prophylaxis. So that's why in an ideal world, we would have testing. But barring the ability to test everybody, stay home and do the normal things you would do if you were mildly ill. Hydrate, keep your fever down, you know, maybe cut back on some of the exercise that you're doing, take it easy. If you are at home with other people and you are a caregiver, that's a person that should wear a mask because you want to protect other people from you. If you have the ability to have other people step in to be a caregiver, that's ideal. I actually tell people, if you have companion animals, don't kiss on their face and stuff if you test positive. The only reason for that, you cannot get COVID-19 from your companion animals. We know that we can transmit it to them. They are not symptomatic when they get it. But COVID-19 is a virus, and the job of a virus is to mutate. So I don't want there to be a situation where a month from now we have a spate of companion animals that are getting sick because we weren't sort of keeping our distance from them. So just, you know, don't necessarily cuddle and that kind of thing with them until you've been cleared by your physician. So those are mild symptoms. Next slide, please. So for severe disease, this is somebody who's going to have more than 50% infiltrates on their CT scan, and that's what this CT scan shows. This is from a Chinese study. This is an actual COVID-19 SARS-CoV-2 patient. So what these folks are going to have is they're going to have more dyspnea or shortness of breath. They're going to have higher fevers, they're going to be coughing, and they may be hypoxic, meaning when we check your blood level of oxygen, it's going to be low. They may have developed ARDS, and like I said, I'm going to go over what that is in a minute. These are the folks that need to seek medical attention. So ideally, you're going to call your doctor first, and they're going to help guide you to where you need to go. Do not go to your primary care clinic. That is not the appropriate place to go. If you are severely short of breath or hypoxic and you cannot wait to speak to your doctor, then absolutely go to an emergency room. Realize when you get there, the treatment is still the same. It is supportive. Depending on the community you're in, they might actually send you home. If your oxygen levels are low, but not low enough to need oxygen, they may just say, go home, we'll check in with you periodically, right? If you do need oxygen, many locations have the ability to emergently set up oxygen so they don't need to admit you to the hospital, right? The idea is we need to keep the ICU and the hospital beds for the people who need further higher levels of care. And if we can keep you out of the hospital, we're decreasing the risk that you're going to get a hospital-acquired infection from being in the hospital. So it is possible that even with severe disease, they may send you home. But again, that's going to be between you and the healthcare provider that you are seeing at the time. Next. So the critically ill patients, and this is about 5% of people, these are the folks that have severe respiratory illness. Next. And that's what their CTs look like. So they're now developing extensive damage. They're also, it's very common for these folks to develop shock, whether that's from sepsis, which is overwhelming infection, or from cardiovascular collapse, which is another way that this disease is very different than the flu. What we're seeing that's very scary to us is a patient will be doing great, they'll have no indication of heart problems, and then all of a sudden, they'll have complete cardiovascular collapse. And we often can't recover them quickly enough from that. They'll often also have multi-organ dysfunction, so their kidneys might fail, their liver might fail, that kind of thing. So for these folks, the treatment is a higher level of care. So that's why these folks need to be in the hospital and often in the ICU. So we might need to give them a higher oxygen delivery mechanism. So for example, things like something called high flow oxygen. There's also a non-invasive form of positive pressure ventilation called BiPAP. So positive pressure ventilation simply means that instead of us going and generating negative pressure in our chest and air comes in, we're actually delivering air into the lung. So it's a totally different way of, your lung physiology changes a little bit because now all of a sudden you've got positive pressure in your lungs. There's two ways we can deliver that. We can do that non-invasively through a BiPAP mask. The problem with high flow and BiPAP is there are very, very, very high rates of infectivity to everybody else in the room because you're essentially aerosolizing the particles everywhere. When you intubate someone, when you put a tube down their throat and you put them on a ventilator, you have immediate source control because the patient is getting air into the tube and it's going right back into the tube. So depending on what your hospital's situation is, they may opt to say, no, we're not going to do BiPAP, we're not going to do high flow, we're going to go straight to intubation. For the very, very, very severe cases, we can do ECMO, which is very high risk. It's a very specialized thing. Very few people can do it. We'll talk a little bit about that in a minute. Next slide, please. Next. So I just wanted to show you a couple more slides of the gradual progression of SARS-CoV in a couple patients in China. Next slide. So this is one of the worst, and this is actually, believe it or not, fairly common. This is what we see when we see ARDS. So if you look at section C and D, do you see the holes, Sailesh, in the lungs?
Right.
That's completely destroyed lung. That's not coming back.
Wow.
That's totally, completely destroyed lung. So this is why we're telling people stay home, because this is what we need to avoid, right? Mm-hmm. Next slide. So what are the treatment options? And you can see that I've got it in quotations. So we've tried a couple different things. As I said, COVID-19 is an RNA-based virus, so highly antiretroviral therapy, which we use for HIV and AIDS. We've tried that because HIV is also an RNA-based virus. So unfortunately, this has really been devastating for the medical community. One of the big drugs that we were trying is a drug called Kaletra, which is a combination drug of lopinavir and ritonavir. And unfortunately, the most recent data that was published in the New England Journal of Medicine last week has shown that it failed. It failed to change the number of days a patient was on a ventilator, and it failed to improve mortality. So the other two things that we're seeing a lot of right now, and unfortunately, because certain politicians have advertised these as cure-all drugs, patients who actually need this drug don't have the ability to get this drug, hydroxychloroquine and chloroquine. So chloroquine is a routine malaria drug. I'm sure you're very familiar with this medication, Sailesh. We don't use it in India anymore because India is now a chloroquine resistant area for malaria. Hydroxychloroquine can also be used for malaria, but it's also very commonly used for rheumatologic disease like lupus and psoriatic arthritis. So about 3 weeks ago in Atlanta, you could not find any Plaquenil anywhere. Lupus patients weren't able to get this medicine because people were panicking and hoarding this drug. Here's the problem. There's no evidence that it works. We're basing this on scientific theory. There are no studies that show that it works. The one study that everyone is hinging their hats on, there were 24 people in the treatment arm, and they said 4 of those patients were lost to follow-up. Except those 4 patients, 1 of them died and 3 went to the ICU. That's not lost to follow-up. They were just taken out of the analysis. So 4 out of 24 patients worsened, but they were taken out of the analysis. I would say that you cannot say that this is a drug that works definitively. We're often combining these drugs with azithromycin, which is a very common antibiotic. But the problem is all three of these drugs can cause something called a prolonged QT interval, where they basically affect the electrical impulse in our heart. If your QT interval prolongs long enough, you develop a fatal arrhythmia called torsade de pointes. So if you're taking this stuff at home because someone told you that this is a drug that's going to help you and that it's going to be a good prophylaxis, you're going to die of an arrhythmia at home before you can be seen in the hospital. If this happens in an ICU where you're being monitored, we can fix that problem immediately, right? If you develop QT prolongation, you're getting EKGs daily to monitor your QT if you're on these drugs, right? The reason we're using these drugs, again, is because there is scientific, mechanistic theories that this would work. But again, we need to wait for the trials to be completed to see if they're truly going to work. The other thing to remember is most of the patients who are very sick who are on these medications are also on other medications like Zofran and other anti-nausea medicines that also prolong QT intervals. Another drug that is currently in trials is remdesivir. So this is a drug that's being made by Gilead, and for a brief period of time, they were able to offer it for compassionate use. In other words, your hospital team would get together, they would petition Gilead and say, look, we've got this critically ill patient. Nothing is working. At this point, this guy is definitely going to die. We have nothing to lose. Let's try this drug. And Gilead could offer it. But we knew that at some point Gilead was not going to have enough drug to do this. And now we're at that point. Now they've had to narrow. I think now it's for pregnancy and for young children, they can still offer it. Otherwise, they're using it in a trial situation. And that's really what we need, right? We need randomized controlled trials that are well designed, that are not based on panic. Mm-hmm. So another thing that we're seeing is vitamin C. There's a lot of data on vitamin C with sepsis and ARDS. There is no data on vitamin C and COVID and ARDS. So the Citrus ALI trial, CITRIS-ALI, is a trial that looked at very high dose vitamin C in the setting of someone who has ARDS related to sepsis or overwhelming infection. The interesting thing about that trial is they were not looking at mortality. The trial happened to show mortality benefit, but that was not the point of the study. So we don't know for sure that this is going to work in people here. Are people doing it? Sure. I mean, there are folks in New York that are doing it out of desperation. There isn't enough data to make a blanket statement that everybody should be using vitamin C in this case. Not everybody who has ARDS with COVID develops sepsis. And this is really aimed at people who are septic. There's also no evidence that if you load up on vitamin C at home, that it's going to prevent you from getting COVID. I mean, yes, we want you to have good stores of vitamin C in general because it does boost your immunity, but there's no guarantee that if you start slamming crazy doses of vitamin C, that it's somehow going to protect you from developing ARDS. Now, one thing that is, to me, very promising because it has, to me, the highest likelihood of success is obtaining plasma from previously infected persons. So if you've had COVID-19, you've cleared it, we're testing you to see if you've developed antibodies to it so that potentially we can isolate those antibodies and then give them to people who are still struggling with severe disease who may not have the immune system built up well enough. Yep, that's my dog. Sorry, you're going to hear a lot of that. So the antibodies may actually help shorten the course of disease. They're not going to prevent disease, so we're not injecting them into everybody to prevent disease, but they may shorten the course. There are some anti-IL-6 therapies. So these are monoclonal antibodies to interleukin-6, which is an inflammatory cytokine that is very highly upregulated in COVID-19. Anti-IL-6 therapies are actually used for things like rheumatoid arthritis and other rheumatologic conditions. So those are currently being trialed. So it is possible that they may help. But as with all immunotherapies, there are very severe side effects to these. So we're not just going to start throwing them at people. There has to be, it has to be in a very calm, dispassionate way that we say who we're going to give it to and who we're going to attempt to give it to. So these aren't things that are guarantees. There are some other immune modulators. There's a lot of stuff in the news right now about interferon alpha 2b, which Cuba is giving to a lot of different countries. The US, because of our relationship with Cuba, doesn't have access to this. So there is some promising data with interferon. We used to use interferon alpha 2b with hepatitis C. We don't anymore. Now we use antiretrovirals, and there's a 97% cure rate now with hepatitis C. But the problem is that interferon alpha has some very serious side effects. So giving this to somebody who's already severely ill can be challenging. So again, this is another thing that is currently being trialed right now, but there is no guarantee that these things are going to work. And so it has to be a case-by-case basis. Okay, next slide. All right, so ARDS, what is it? So just because I'm a medical history buff, I'm gonna go through this one slide and then I'm gonna skip a couple slides. There's a lot of detail on epidemiology in the next few slides. Since you're gonna be posting the slides, Sailesh, I just wanted people to have access to that and they can look at it at their leisure. But in the interest of time, I'm not gonna go through a lot of the detail. So ARDS was first described in World War I, and at the time it was actually called adult respiratory distress syndrome. And what people were finding is that patients who were having non-thoracic injuries in war, a few days later were developing lung injury, and it was unexplained. So people who needed massive amounts of blood were developing lung injury, and it didn't make sense. People who had pancreatitis or had leg trauma would suddenly develop this. In 1967, Ashbaugh and colleagues were the first people to describe this in 12 people, and they termed it adult respiratory distress syndrome. Next slide. In 1994, they came up with a definition. Basically what it is it's an acute lung condition that is characterized by bilateral, meaning on both sides of the lungs, pulmonary infiltrates, specifically fluid buildup in the lungs, also called pulmonary edema, that is not related to heart failure. That is the key. So the most common cause of fluid buildup in the lungs is going to be that your heart isn't pumping well, and so it's causing backup of fluid into the lungs. That is not what ARDS is, and that's a very important point. Next slide. Okay, so I'm just going to skip through this. Next slide. Next slide. So we now use the Berlin definition. This is from the New England Journal of Medicine. The only thing I want to point out from this table is if you go down to characterization of ARDS severity, if you look at mild, moderate, and severe, the way we characterize this is something called the P to F ratio, which is essentially what your oxygen level in the blood is based on the amount of oxygen we deliver you. So if we give you 100% oxygen and then we test your blood, how much oxygen are you able to build up in your bloodstream? So a normal person, if you put me on a ventilator right now, I don't have lung disease, and you put me on 100%, I hope you don't, because that's gonna give me oxygen toxicity. But if you did, and then you checked my blood, my PaO2 should be in the 450 to 500 range, okay? People with severe ARDS are sitting less than 100. People with very severe ARDS, which I see routinely in my ICU, they'll sit at 55. 55 is the absolute lowest we will allow, because we know that 55 is the lowest that we can give somebody without causing brain damage and heart damage and kidney damage. But a PO2 of 55 is grossly abnormal. But the reason I wanted to show this slide is if you look over under rationale, where it says mild, moderate, severe, you'll actually see mortality statistics there. So the mortality for mild ARDS, and this is not COVID, this is ARDS from everything else, is 27%. For moderate, it's 32%, and for severe, it's 45%. And remember, we're seeing much more ARDS with COVID than we do with other diseases. Next slide. So I'm going to skip through this. This is just stuff on incidence. The major important thing to know here is that the incidence of ARDS is basically stable over the last 10 years, although mortality has dropped because we're getting better at recognizing it and we're getting better at treating it, with one notable exception, and that was 2009. What happened in 2009?
The swine flu?
Absolutely. There was a pandemic. Right? So we can expect, the expectation is that mortality is going to bump up again this year. Okay. There are still some disparities with ARDS survival, and I'll go over that in another slide. So we can go to the next slide. So mortality pre-ARDSNet. So ARDSNet was the large trial that was the first thing ever to show any mortality benefit. We do 1,000 things to treat people with ARDS, and only 2 things have ever been shown to have mortality benefit. And I'm going to go over some of them. Prior to ARDSNet, which is, so the ARDSNet trial basically looked at a unique way of ventilating patients. And this is not the way that the average person who knows how to manage a ventilator in an OR, they don't know how to manage a patient with ARDS. It's a very unique way of ventilating people. So prior to ARDSnet, mortality was as high as 70%. We're sitting pretty steady at about 40%. And then of course, obviously, if you have severe, it's a little bit higher. Here's the scary thing about ARDS that I think a lot of people don't understand. And this is why it is so imperative that we socially isolate regardless of our age. The 1-year mortality for ARDS is worse than the 30-day mortality. So if you survive to 30 days, great. But you are twice as likely to be dead by the end of the year. So if you survive ARDS, you have significant disability and you have a significantly shortened lifespan. Most folks with ARDS are on oxygen long-term. Even a simple cold can be the thing that kills them. They have profound shortness of breath all the time because their lungs are so scarred down that they're unable to fully expand their lungs. It's a very miserable disease to survive. And this doesn't even take into account the PTSD that we know that all ARDS survivors have from being critically ill on a ventilator. When you have ARDS and you're on a ventilator, we often have to paralyze patients because they're so dysynchronous. We call it bucking the vent. They're fighting the vent because it's such an uncomfortable feeling. Now imagine doing that for 22 days. That's why we're asking people to make that decision to stay at home. Next slide. So these are some of the common risk factors. The ones that are highlighted in red are the ones that we tend to see a lot of. So pneumonia, obviously, the reason we're seeing it with COVID is because it is a pneumonia that's being caused. Sepsis, again, is overwhelming infection. But you can have a car accident and develop ARDS. We'll see it with pancreatitis. We see it in lung transplant patients a lot after reperfusion. And then drug overdose is an important one. And I'll talk about that a little bit in the next slide. So I'm not going to go over this in detail. You can go to my Instagram, which is at _theVegDoc, or though I tend to be very private on Facebook. I have made all of my posts about COVID-19. I'm very sorry about the dog. He is clearly barking at someone walking down the street. But, you know, one of the, Kobe.
It's okay.
I'm sorry.
We can hear you.
Okay. All right. So the thing with alcohol is you can actually go, you can go to my, my Facebook page, and there's actually a link to an article, and I can email that to you if you want, Sailesh, and it's a great review article. So most people don't realize that chronic alcohol very clearly increases your risk of ARDS, and there's a whole slew of biomechanical things that happen to cause that. Here's just a simple list of that. The reason I know about it is I trained at Emory, and the Emory docs, my mentors, are the ones that first figured this out. So the larger issue is that what I'm telling people is, I'm just telling people, look, drastically cut back on it, or just abstain from it. There's no nutritional benefit to alcohol, right? I mean, it's very easy to want to drink right now if you're home, trapped at home with the kids and your husband and your wife and all this stuff, and you don't really have an outlet. But just realize you are increasing your risk of ARDS, and you can go over the details of that on my Facebook page. Or the easier one would be my Instagram. Next slide. So what are the factors for poor outcomes? Males definitely do worse with ARDS than females, given the same degree of ARDS and the same acuity of illness. We know that African Americans and Hispanics do worse. Some of that is related to access to healthcare, but some of it is actually related to genetic polymorphisms that I won't go over here. Obesity is a little bit hard. Some studies say that obese patients do worse with ARDS. Some patients say that they don't, and some studies show that they don't. The major challenge with obese patients, ventilating them, is it's very challenging to ventilate an obese patient. One of the things that happens with ARDS is that your lungs become very, very stiff. They become less compliant. If you have a large, heavy chest wall, that impacts compliance. And it's very hard for us when we're looking at a ventilator and we're looking at waveforms on the ventilator, and I'm looking at the pressure waveforms. It's hard for me to know how much of that is the actual lung compliance going down and how much of that is the physical compression from a chest wall. And then of course we know that older people do worse with ARDS. So, you know, I don't want people to get bogged down in the minutia of this. The reason I'm discussing this in this degree of detail is I want people to comprehend, even if they don't necessarily understand the details of what I'm saying, I want them to understand how complex a disease process this is. When I'm in an ICU and I have 12 patients and 4 of them have ARDS, that's a busy day for me. Now imagine a 20-bed ICU and every single patient's on the vent and every single patient has ARDS. We know from multiple studies that if you are an ICU doctor, the ideal ratio for good patient outcomes is 1:12 to 1:15. Okay. In the winter, I sometimes have 20 patients that I'm seeing in an ICU. When I have 20 patients that I'm seeing in an ICU, I don't have the luxury of spending enough time with every patient where I'm actively every day trying to get that patient to improve. Sometimes I'm just trying to make sure they don't die, right? Now we can talk about why hospitals don't staff ICUs better in the winter. That's a whole other discussion that I'd be happy to have at another time. But that's the reality of medicine, right? Now imagine you're on a ventilator for 22 days and there's 20 other patients in there. Right? So in New York and Italy, they're drafting doctors, they're drafting orthopedic surgeons, they're drafting people who haven't touched a ventilator since their residency to now manage these patients. So if you decide to go to a COVID party, or you decide to go to the grocery store when you don't need to, and you get sick, or your mom gets sick, is your mom going to get a doctor like me, or are they going to get an orthopedic surgeon that was handed a sheet of paper on how to manage a ventilator? Because that's the reality that we're facing if we don't buckle down.
Right.
Next slide. So very briefly, I'm going to go over just a tiny little bit of pathophysiology. There's essentially two major phases to ARDS. The first phase is the acute phase, which is where everything is damaged and inflamed. Next slide. So this is from the New England Journal of Medicine, 1996. This was the seminal paper that summarized what happens in ARDS. So the left side of this is a normal alveolus or air sac. Okay, so all that white that you're seeing in there, that's air. So air comes into the air sac and then it diffuses through down to the capillary, which is the red thing down at the bottom, and oxygen is picked up by the blood. Well, what happens with ARDS is we have this overexuberant immune response to infection or trauma or pancreatitis or whatever the case may be. And again, if you are a chronic alcoholic or you drink to excess on a routine basis, you have depleted protective mechanisms in your lungs, so you're already more prone to have damage. What ends up happening is you now have massive leakage of all of these inflammatory cells that are coming to the rescue, and they now flood your alveoli. And they do it in a very heterogeneous manner. So some areas of the lung are fine and are not damaged, and then some areas are flooded. And that really causes problems when you're trying to ventilate people, because if you put too much air into the lung, the good areas get damaged, the bad areas nothing happens to. So it makes it very complex to ventilate these patients. But this is essentially what happens in the exudative phase. The scary part is the next phase. So next slide. So this is when people fibrose down. They basically scar down. The inflammation leads to complete obliteration of the architecture. As I said, this is another SARS-CoV-2 patient from China. Those holes are damaged. That's never going to recover. You cannot regrow lung. So that's permanent damage that this person is going to have for the rest of their lives. Those are permanent lung units that they have lost. Okay, what also can end up happening is they can get thickening of the lining of the lung. So now you've got all this scarring within the lung and the lining of the lung. So when you take a deep breath in, your lung can't fully expand. So imagine if you had to wear a binder, like an abdominal binder, but someone wrapped it really, really tightly around your chest, and you just had to live that way for the rest of your life. That's what survivors of ARDS feel on a daily basis. Next slide. So this is just for people to peruse on their own. If you'll go through the next two slides as well, please. These are currently the treatment options that we have for someone with ARDS. And this is not, this is for COVID-19, but this is not unique to COVID-19. This is how we would manage any ARDS patient. The difference being that when it says things like, consider high flow oxygen instead of putting someone on a ventilator, consider a BiPAP instead of putting someone on a ventilator, you have to very seriously consider the risk that you're putting yourself and all of your staff at by putting them on those two particular therapies, because those two particular therapies have a high rate of infection of everybody else in the room, whereas intubation has a lower risk. Because once they're intubated, again, they're not aerosolizing particles into the air. Next slide. So the only reason I put this up, this is super old school. This is like from the original ARDS trial. So we talk about things like alkaline and stuff like that. We can have a discussion about why there's no evidence why alkaline is an actual thing that works. But in a nutshell, your lungs and your liver control your blood pH. okay? And our blood pH on average is going to be between 7.35 and 7.45. There's a couple medical conditions where you might run a little bit lower normally, but traditionally 7.35 to 7.45 is where you're going to live, okay? When we are managing patients with ARDS, because not only do they not oxygenate, meaning oxygen doesn't come in, they don't ventilate, meaning carbon dioxide doesn't come out. When we have higher and higher levels of carbon dioxide, your blood pH drops. Eventually, it affects your brain and you stop breathing, right? So when someone's on a ventilator, it doesn't necessarily matter if they're able to breathe because we're determining how much they can breathe, right? We're setting how much they can breathe on a ventilator. But the reason I put this slide up here is ARDS is a disease that is so bad that I will happily live with a patient at a pH of 7.2. I don't start to worry until they drop to 7.1. Enzymes denature at 7. So the only reason I bring this up is I don't want to scare people. I just want people to understand this is a very severe, very complex disease. And when people in New York, when doctors in New York have entire ICUs full of patients on ventilators with ARDS, this is a very serious problem. They're trying to split ventilators. And every patient is unique. You have to dial in all of the vent settings, very unique to every single patient. I have no idea how you would ever split a ventilator between two different ARDS patients.
Right.
Next slide. So other considerations. In the past, we used to do something called high frequency oscillation ventilators. We don't do that anymore. We have to worry about fluid management. There's trials to show how to do that. We'll do things like we'll give people inhaled nitric oxide, which is a vasodilator. It helps to improve oxygen. But like many things with ARDS that we do, it will improve the oxygenation, but it shows no benefit on mortality. There are many things in ARDS that we do that in the short term make you feel better because their patients' oxygen levels go up, but it doesn't change their survival. Inhaled nitric oxide, also you run the risk of renal dysfunction, kidney problems with it. One of the big risks with ARDS is when we ventilate these folks, we can actually blow their lung. We can cause a pneumothorax. If they have enough stress to the lung, we can actually cause complete collapse of that lung. If you're on positive pressure ventilation, you are very likely to have a cardiac or respiratory arrest if you have a pneumothorax. In the olden days, before we used to do low volume tidal ventilation, when someone had ARDS and was put on a vent, they just put 4 chest tubes in people immediately, because they knew they were going to blow their lungs. We don't do that anymore. We've learned how to manage them so that doesn't happen. But yes, I've thrown emergent chest tubes in patients because they've had a pneumothorax with ARDS. Next slide. So this is the one promising thing. For many, 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 many years, we had 4 or 5 different randomized control trials that showed proning patients did not improve outcomes. And it turns out the reason for those trials showing no benefit is likely because we just weren't picking the right patient population. For the folks that have the very, very severe ARDS, the worst of the worst, when we flip them over, we literally put them on their bellies, it actually does improve oxygenation. And more importantly, it improves mortality. That's the Prosiva trial. But here's the problem. This is the most terrifying thing to do in an ICU, in my opinion. And I've put people on ECMO. This is the most terrifying thing, because when you flip a patient, if the patient is larger, you need multiple staff members to flip them properly, right? When you flip them, you're risking the tube being dislodged from their mouth. A patient with severe enough ARDS that you're trying to prone them, if their tube comes out, they're going to have a cardiac or respiratory arrest immediately, right? If they do have an arrest because they get sick or they have the complete cardiovascular collapse that we talked about, now we're wasting precious time because we have to flip them back over, right? So that we can run a code on them. But we also risk dislodging all of the other apparatus that these folks often have, right? People on ventilators usually have a line maybe in their radial artery to help monitor blood pressure. They'll have a line in their neck so that we can give them lots of different medications. And all of these things can be dislodged when we're moving them, right? But we know that this works. It's high risk, but we have to do it because there's benefit. Next slide. Next slide. Okay, so the last thing is ECMO. So this is when we do bypass outside of the ICU. So what we basically do with this is, you know how like when you dialyze someone, you're basically taking the blood out and you're purifying it of bad things, right? So in this situation, what ECMO does is we're taking the blood out, we're running it through an oxygenation circuit, and we're allowing the lungs to rest. Now, there's two different types of ECMO that we can do, and we don't need to talk about that here, but the thing to know is if you qualify for ECMO, your mortality is between 70 and 90%. For us to pull the trigger on ECMO and say you're a candidate for ECMO, your mortality is between 70 and 90%. Okay, only highly specialized centers are doing this, and each center may only have 1 to 3 ECMO beds. Now, there are some centers in the US and in Europe that have what we call mobile ECMO, so they'll fly down, they'll put you on ECMO, and they literally put you in a van, and then they drive the van onto a truck because you can't really move these folks very well. In some centers like Columbia Presbyterian, they're doing a really great job. They actually will put people on ECMO for COPD exacerbations so that they can take them off the ventilator and people can walk around. We did that in lung transplant. If we were bridging someone to lung transplant or someone had really bad graft dysfunction after lung transplant, we would actually just put them on a special kind of cannula, put them on ECMO, and they'd walk around so that they weren't having muscle wasting. That's a big problem when patients are bedridden for 22 days, right? They all develop critical illness myopathy. They develop peripheral neuropathy from being critically ill. When you're put on a ventilator for 22 days, within 4 hours of being on the ventilator, your diaphragm starts to atrophy. So your major breathing muscle starts to get weak. Imagine what it's doing on day 22, right? Next slide. So steroids are not indicated for ARDS or for SARS-CoV-2. You can look at the data later. Next slide. So finally, the summary. So I hope that these slides have shown you guys that COVID-19 is a virus which causes SARS-CoV-2, is a deadly disease that has very high infectivity. Young patients are not exempt from severe illness with severe morbidity and mortality, meaning severe consequences if they survive. Isolation is the key to avoiding spread. Masks will not protect you from COVID unless you're wearing an N95. For the love of God, please don't be wearing N95s. Please donate those to the folks that are really, really high risk. I have colleagues who are testing positive because they don't have PPE. They don't have N95s to wear. Now, if you have surgical masks and you are sick, absolutely wear one to protect you, to protect your family from you. That makes sense. Right now, I think the CDC has just basically thrown up their hands and said, fine, everybody wear a mask. So now if everyone's wearing a mask, everyone's protected from each other. And so, I mean, that may be where we're at, but that's literally a parent going, the kids aren't listening. This is what we have to do. I mean, that's literally because the nation is non-compliant. Next slide. So again, there are no currently proven therapies to prevent or treat COVID-19. There are many experimental therapies. Some are promising, some not so much. We just need to wait till the trials come out, which is a very hard thing for people to understand when people are dying. Sometimes the best thing to do in medicine is to be patient. The importance of flattening the curve is to not overwhelm hospitals and staff. So one of the things that I try to impress upon people is when you're thinking about going out to get that takeout or going out to that grocery store and you maybe don't really need to, picture me, picture the risk that I am being put at if I get overwhelmed in an ICU. Picture the nurse that you know, right? Picture the environmental services folks that work in the hospital to keep it clean, right? There are really real people on the other end of this who are dying, trying to take care of patients. Next slide. So again, ARDS is a very devastating disease, and if you survive it, you will have permanent disability and a shortened lifespan. So please stay home. Now, the next couple slides are what can we do? Next slide. So there are 19 things that I think that we can do to protect ourselves. Okay. So next, stay home. Next, stay home. Next. Really, seriously, stay home. Next. Numbers 4 through 10, stay home. For the love of God, stay home. Next. So yes, obviously we want to practice good hygiene, frequent hand washing, don't touch your face. That's really challenging for everyone to do. Now, I will say one good thing about if you go out to a grocery store and you don't have a mask and you want to put something on your face, wear a bandana. To me, the larger benefit of the bandana is it reminds me when I'm going to pick up that almond milk, not to then go touch my face because I've got a bandana on. So that's one benefit of doing that. Wipe down commonly used surfaces. So we think about things like the microwave, the fridge. We're not necessarily thinking about doorknobs, you know, bathrooms, faucets, that kind of thing. So you do want to wipe those down with approved things. You can go to the CDC website to see which are approved for killing viruses and which ones aren't. Next slide. So yes, we should be eating a whole foods plant-based diet with little or no oil. Now, there's a lot of woo-woo out there about supplements and CMOS and all this other stuff. That's just not how immunity works. You can't take CMOS and then boost your natural killer cell ability or your B cell ability or your T cell ability. That's not how cellular immunity works. That's not how humoral immunity works. But here's what we tangibly know about eating a whole foods plant-based diet. We know that the people who are at highest risk are the folks with hypertension, type 2 diabetes, cardiovascular disease, possibly obesity, right? What is your best chance of not having those high-risk comorbidities? A whole foods plant-based diet, okay? We do also know that eating a whole foods plant-based diet does help with immunity, right? I mean, we know that we change gene expression. We know that we promote anti-inflammation genes and we shut off pro-inflammatory genes, which are all very helpful. So there are tangible effects to a whole foods plant-based diet. I just don't want to exaggerate what those effects are. Vegans and plant-based eaters can still absolutely get COVID and get very sick from COVID. Next slide. Exercise. This actually tangibly improves immunity. So studies have shown that if you do moderate exercise for 30 minutes and then you check your white blood cell count, your white blood cell counts go up. Right? So you have promoted immunity. Now, there's a couple caveats to that. If you're like a marathon runner, you're actually going to depress your immunity. So excess exercise will typically depress your immunity. But if you do regular, moderate exercise, the minimum amount is 150 minutes a week, you are going to boost your immunity. If you can't run or walk, if you have limited mobility, do chair exercises. There's always something you can do to improve your immunity. Next slide. So getting good sleep. We absolutely know that when people do not get good quality sleep, it tangibly depresses the immune system and increases risk of illness. So one of the reasons that we suspect that people do get sick during times of stress is because they're not sleeping well. And that brings me to my next point, which is practicing stress reduction, because we know that in high stress situations, when you've got cortisol pumping through your body, it does depress your immune system. And I suspect that is a great reason why, combined with the high exposure rate of healthcare workers, the stress and lack of sleep and exhaustion is what's causing them to be at risk for infection. Next. So we do have to physically isolate, right? But the big thing is knowing that loneliness and depression can also depress your immune system. So we don't want people to socially isolate, right? Particularly if you know older people. So older people in particular are very susceptible to this. So make sure if you have a way of getting an iPad to them or a phone or even just talking on the phone, the millennials will freak out about this, but believe it or not, texting is not the optimal way to communicate with people, right? Pick up the phone and call your grandma. If your grandma lives in a nursing home, find out if there's a way that you can if you play guitar, play music for the residents of a nursing home. We need to look out for each other. That's hugely important during this pandemic. Next slide. So, and again, we want to avoid risky behaviors. We absolutely know that if you smoke, you are at increased risk of developing lung problems and ARDS, and you have a higher risk of infection with COVID. So if there is ever a good time to quit smoking, it is now, okay? And again, we talked about the alcohol. Feel free to look at my Instagram post that has all the data and has the review article that goes over all of the data. Next slide. Finally, there's a couple other things we can do, right? We know that if we stop commodifying animals at all levels, everything gets better, right? We reduce future pandemic risk. We improve human health. We improve planetary health. And most importantly, we improve animal health, right? So if we stop doing these things, we can prevent the next one from happening. I think we have proven beyond a shadow of a doubt, at least in America, that we do not have the infrastructure to support our poor, are disenfranchised, This, if nothing else, COVID-19 has revealed the cracks in our society, which leads me to my next point. Use your vote, right? Don't vote for the people who don't believe in science. Don't vote for the people who don't believe in universal health care and a living wage and basic income and pensions. Other countries can do this. I worked in Australia for almost a year, and nationalized healthcare is phenomenal. I actually have money sitting in a bank account there from a pension that they want to pay me for having worked there for a year. I mean, it's not much money. I was there for a year, but this is what we can do for everybody, right? There's absolutely no reason that small businesses should be collapsing. There's no reason that wait staff should be deciding between rent and medicine and food, but that's where we are because we don't pay people a living wage, and we have the power to help other people. You know, so I'm going to try to get off my soapbox here, but you know, when we go from president to president, I'll be honest with you, a lot of things most of that stuff doesn't affect my life on a day-to-day basis, but it does affect everybody else, right? And so if I'm not here to help other people, why am I here on earth, right? So we need to use our vote to make sure that we protect the least fortunate of us, especially if we're vegan, right? Why are we vegan if we're not vegan to help vulnerable people?
Right.
Okay, soapbox over. Next slide. And that is it. So I am happy to take questions. I apologize. I know this was a very long presentation.
Thank you. Thank you so much. I think I speak for everybody to say, when I say that this was an amazing presentation.
Thank
we
you.
learned a lot. We learned a lot from you. There are a lot of questions, I'm sure. So I'm going to just throw it open to the...
Yeah, and I have plenty of time, so...
Okay.
Okay. Hello, and thank you very much. We have a question about, can you say anything about x-rays? Do they show anything about COVID? And then the next question is about young children. If they are dying and susceptible, are there tests for children under 9? The place that Amy called said they don't test children under 9 years old.
So they're probably not, so the test is, the age is irrelevant because the testing that we're doing is something called real-time PCR. So we're actually testing for actual virus replication. So we're actually looking for the virus on the test. So that's independent of age. I suspect that they're not testing people under 9 because people under 9 are not likely to be significantly ill. And again, the reason this is happening is because our leaders chose not to get tests here. If we had the WHO testing kits, this wouldn't be an issue, unfortunately, right? So that's why. So every time someone gets upset that we don't have testing available or someone's being turned down, realize it's not because the healthcare community doesn't want you to get tested, it's because there are not tests available. So children can get sick from this. We are unfortunately seeing that I think there was a 13-year-old boy that just died in New York from COVID-19. So it tends to be less likely. We're not seeing it as commonly in children by far. And I don't know, again, if that's because they don't tend to have hypertension at age 9 and they don't tend to have, you know, type 2 diabetes and cardiovascular disease and all of these other things. But it's much less likely that children are going to get it. And I think I forgot what was the first part of that question.
About x-rays and COVID.
Right. So x-rays are not likely going to show anything meaningful in a way that's going to change management. And here's what I mean by that. So remember I said that in China, we found that people who test positive but don't have symptoms, they already have minor changes on CT. It's harder to see those on a chest x-ray. So the analogy that I use with my patients when I compare a chest x-ray to a CT is imagine your backyard is flooded, okay? When you look at a chest x-ray, it's like you're using a drone hovering over your backyard to figure out where the flood is happening, right? A CT is a closer look. So it's like you're standing on your back deck to look at where the flood is coming from. So the early minor changes on chest x-ray are not going to be helpful. And the other thing about a chest x-ray is it's very nonspecific. So you can't necessarily differentiate between fluid in the lungs from the heart, fluid in the lungs from pneumonia. A fluid collection in the lining of the lung can obscure the way a chest x-ray looks. So if someone is severely ill at some point, they are most likely going to get a CT. But if they're so severely ill, to some degree, what the CT shows is irrelevant initially, because you're going to need to be put on a ventilator and you're going to get daily chest x-rays to make sure that, you know, your ET tube is in the right place and all of that stuff. And how you do clinically and what your ventilator mechanics are far more important at that point than what your imaging shows.
Wow, thank you very much. One of our callers asked if you know much about stage 4 lung cancer and Keytruda immunology treatment and COVID-19. Should a patient be tested for the virus when in a chronic respiratory situation?
Yeah, so Keytruda is an immunomodulator for lung cancer. So there's two things that you need to do if you are currently being treated with chemotherapy. You are immunocompromised, okay? So you absolutely need to communicate with your oncologist, and potentially if you still have a pulmonologist. Sometimes once the patient has been diagnosed with lung cancer, we're not necessarily seeing them, the oncologist is seeing them for everything. But I would touch base with your oncologist to find out what they want to do. They may say, we want to wait to give you Keytruda. Keytruda, in very rare instances, can cause something called a pneumonitis. It's a known side effect, which unfortunately on imaging and physiologically can look like ARDS, but the pathophysiology is different. So people may say, for right now, if your lung cancer is not aggressively progressing, they may choose to say, let's hold off on giving you Keytruda. They may say, no, you have very aggressive lung cancer, we need to continue the Keytruda. But that's really a decision that needs to be made between you and your oncologist.
Okay, thank you. Another person asked, he's an older person and he has a DNR for in case of a heart attack, but should there or is there anything that one should consider for this? I guess that sounds terrible.
So actually, this is one of my favorite questions, believe it or not, because as a critical care physician, one of the most frustrating things I deal with is end of life decisions. And what I mean by my favorite question is, families need, regardless of COVID-19, families at all times need to be talking about this stuff. In my 30s, I told my parents what I wanted in the case of catastrophe. So everybody needs to kind of make their own decision. DNR, do not resuscitate, specifically usually means two things. It typically means in the event of a respiratory arrest, you're not going to go on a ventilator. And it means in the event of a cardiac arrest, you're not going to opt for CPR and shock and that kind of thing. Some people will also add in, if you develop shock, you're not going to be put on medications called pressors, which are this, it's a pretty strong medication that we give in a continuous IV form. It has to be done in an ICU and it keeps your blood pressure up, but it's falsely elevating your blood pressure and you wouldn't necessarily be able to survive without it. So some people will add that to that. The most important thing is for you to have conversations with your physician and your family about what you would want for yourself. So for example, if you are somebody who says, this sounds awful, I don't want to go on a ventilator at all unless the doctors think I have a decent chance of recovery, then you need to tell your family that. And if you are able, because again, remember, patients are crashing so quickly, you may not even have the breath to have that conversation with somebody. But having that conversation with your family helps, because even if your family isn't in the room, the doctor's going to be calling your family to get updates and to talk to you, right? So it's very important that your family is aware of what you want. If you're an older person, what I always recommend, so if someone, for example, is a widowed person and they have children, I always recommend pick one child and have them be your power of attorney. And the only reason I say that is I can't tell you the number of times I've dealt with bickering siblings about what mom or dad would want in the ICU, okay? And sometimes those things are polar opposite. So it's very important that you pick somebody that you want to be your power of healthcare attorney, so they're making decisions for you. But you can't just go, here, I want you to be power of attorney. You have to actually have a discussion with them and say, this is what I would want for myself, okay?
Great, thank you. And the last part of that, I'm interpreting it to mean, and is there a way to slip away quietly by your medical?
So meaning if you are very, very severely ill, do you have to opt for aggressive therapy, or could you opt to just say, make me comfortable? So I'm hoping that's the question. If that is, absolutely. We do that when someone doesn't have COVID. My mother did that. She had terminal lung disease, and at the end of her life, she went on something called hospice. And the focus at that point was keeping her comfortable. The focus was making sure that we gave her medicines so she wouldn't have what we call air hunger, so she wouldn't be really short of breath. And that was the focus. And so you absolutely can do that. Some people feel that, you know, so for example, look, I'll be honest with you, I've had 20-year-olds with asthma attacks refuse to go on a ventilator. And yeah, I mean, I've not been okay with that. And I've consulted the ethics committee. And it turns out the patient had trauma from a bad experience, and we got them through that. So your doctor's not going to do something they don't feel is ethically okay, right? So if you're a 20-year-old who goes, I don't want to go on a ventilator, your doctor's going to have a problem with that. If you're an 80-year-old and says, I don't want to go on a ventilator, your doctor's going to be like, hallelujah, common sense. But the problem is you can't just go by age, right? So that's a big pet peeve of mine. I know 80-year-olds who are running marathons. And I know 60-year-olds who are sitting in a wheelchair, not because they're actually disabled, but because they're, you know, severely heavy or they're sedentary or, you know, whatever the case may be. So it really depends. It's a really case-to-case basis. And that's why the most important thing is talking to your family about what your wishes would be and talking to the doctors and the nurses.
Great, thank you. And let's see, Dot asked, would draining the lungs of the fluids have beneficial effects, for example, with coughing exercises?
So that's a great question. And the answer to that is no, because the fluid is not in a place that can be drained. And here's what I mean by that, unless I'm misunderstanding your question. So I'm going to answer it two different ways. So when we talk about fluid in the lungs, there's two basic places it can be. I want you to imagine a box, and I want you to imagine a sponge in the box, okay? The box is your chest wall. The sponge is your lung. There's a little bit of space around the sponge inside the box. That's called the pleural space. And there's a little bit of fluid that builds up in there. People can develop what we call pleural effusions. We're seeing it a little bit less commonly in COVID, but we can see it. Some of those images on the slides actually do show that. You'll see a couple places where you'll see an arrow pointing to something. That's an arrow pointing to a pleural effusion. If there's a lot of fluid in there and it's actually smushing the lung, it's causing the lung to not fully expand, we'll stick a needle in and we'll drain that fluid. But that's a procedure that has to be done. Sometimes we can give people a diuretic like Lasix, and that can help to drain out the fluid as well. If we don't want to stick a needle in there, they're unstable or it doesn't seem to be necessary. But the bulk of the fluid from ARDS is sitting in the alveoli, really, really, really deep down in the lungs. By the time you have ARDS, coughing exercises aren't going to mobilize that fluid up. And again, it's a continuous leaking of fluid from your capillary membranes and your scaffolding of your lungs. So it's a great idea, but that's unfortunately just not how the lung physiology works.
Okay, great. Thank you. One person asked to say a little bit more about the alcohol. I'm not sure how much or what.
So it's not clear. We know that what ends up happening is you don't have to be what somebody would consider an alcoholic, right? You don't have to be somebody who's falling down drunk every day. You can be like the banker who's drinking 2 whiskeys every night, right? And what happens is there's a whole series of changes that happen in the lungs. So things like glutathione depletion. So glutathione is a very, very strong antioxidant. The highest levels of glutathione in the body are found in the lungs. The second highest levels are in the liver. Interesting fact, when someone has a Tylenol overdose, the reason their liver fails is because the excess Tylenol is poisoning the glutathione pathway. Now, in that situation, you actually give them glutathione to fix the problem. The problem with ARDS and glutathione depletion is they've done studies where they've identified people who are chronically ingesting dangerous amounts of alcohol and have depleted levels of glutathione, and they've actually supplemented them with glutathione, and it doesn't decrease their risk of the development of ARDS. But there's other things that happen in the lung as well, and you can see from the slide all of the things that I talked about. So things like the epithelial wall changes, leaky gap junctions. So again, the idea here is that if I did a chest x-ray on you, if I did lung function tests on you, if I did a CT scan on you, I would see no changes to you if you were drinking to excess. But on a subtle micro level, you have changes to your lung that up to 4 times increased risk cause ARDS if you have an inciting event. And in this case, the inciting event would be COVID, a car accident, that kind of thing. So some studies have suggested that the risk of ARDS is no higher in the general population versus someone who's drinking, as long as they're drinking less than 2 drinks a day. The problem is that for a woman, the CDC considers 1 drink a day moderate drinking. So less than 2 drinks a day would be probably heavy drinking, right? So from my standpoint, again, because alcohol does not have significant nutritional benefit, and we know that COVID is causing a lot of ARDS, my thing is just really think twice about that glass of wine every night or that couple of beers every night.
Okay, great, thank you. Okay, let's see. A company this woman is, Claire was involved in, let's see, a company I'm involved with has a treatment that it would be like to put through a clinical trial. So how about this? So far, we have had no response from leading research hospitals contacted. I'm not sure I understand that. Sorry, Claire.
So is the question, how would you contact somebody? I honestly don't know that either. I do clinical medicine. So the research aspects are lost on me. I mean, you may want to contact the folks at Emory Infectious Disease. You could tweet Carlos Del Rio on Twitter. He was my faculty advisor when I was an intern. He's one of the chiefs of the global pandemic response unit. So Carlos Del Rio, Marshall Lyon, Colleen Kraft, Anish Mehta, these are all Emory Infectious Disease doctors. They're the guys that took care of Ebola. I either have published with them, trained with them, was mentored by them, or I trained them. So I trust all of these guys. I know all of them. They're all brilliant. They're all on Twitter. So feel free to tweet at them, but I don't know that aspect of medicine.
Thank you. And then I have a good question, a little bit more about the mask situation. And that is, if we're healthy and wearing a mask, does it increase or decrease the risk of catching COVID when we're in the community? Now, I know you've talked some about it, but what about how close, if you're wearing a mask, if we know it protects, you said it protects from the
well, so when you're wearing a mask, it's protecting other people from you because it's creating a physical barrier to any droplets that you are spreading through cough, sneezing, or breathing. But if someone coughs on you, it may limit it a little bit, but unless your eyes are covered, your eyes are another point of entry, right? Any mucosa is a point of entry. So when we talk about PPE, protective equipment, what we're talking about also involves goggles, right? Because if someone coughs and I get a droplet in my eye, I can get a COVID infection from that. So the mask itself is not enough. The other thing is, like 90% of people that I see wearing masks are wearing them here. Nose is completely open. You might as well not be wearing a mask at that point, right? You're not only not protecting anybody else, you're not protecting yourself. So most people I know don't wear masks properly. You know, so if you're wearing a mask to go out, like I said, I think the CDC at this point has just thrown up their hands and said, fine, no one's listening, everybody wear a mask. And then at least that way, everybody is, you know, protecting each other from each other.
Great, thank you very much. And we've had a lot of nice comments about your dog, Kobe. Am I missing any others?
In the Q&A, Rebecca, there are a bunch of them in the Q&A.
Okay, let's see.
I've been following the Q&A.
And I have time, so you know, I want to make sure that the goal of this is to reduce anxiety and to get the information out there, so.
Okay.
Yeah. I'm going to just click through some that have already been answered because I think they were listed in both places, but if you want to go ahead.
Okay. Oh. How do you know if you have had ARDS? Could you have it without knowing it until you get a CT scan?
Highly unlikely. You can have mild, very, very mild ARDS and recover from that, but you would most likely still have some symptoms. You might have thought you had a cold a couple weeks ago. This is not related to ARDS, but I have patients routinely that are sent to me for consultation for shortness of breath. I had a gentleman last year, and he's given me permission to share this story. He was a guy who had been very active for many years. 2 years prior, had run a half marathon, and then his job had changed. He'd become very sedentary, and he started feeling bad about that. So he started running again and became very short of breath. So his doctor got a chest x-ray on him and sent him to me. And I took one look at his chest x-ray and I said, you need a lung transplant. And there's no way that you don't need oxygen. I have no idea how you've been walking around like this. And he was just somebody who thought, okay, well, I'm just super short of breath. That's normal. And he absolutely wasn't. And it took us a while. He had a couple hiccups during his workup, but he got transplanted last year. So, you know, so it's very unlikely though that you're going to have ARDS and not know about it, because you are going to have symptoms. And at some point, someone would have gotten an image, right? Because you would have called your doctor and been like, man, I'm so short of breath. And they're going to say, okay, well, go get a chest x-ray and then I'll take a look at it and let you know what's going on. We can see ARDS on chest x-ray. That's how we first identified ARDS in patients. And we do use x-rays to stratify the severity of ARDS. But it's highly unlikely that you would have ARDS and not know.
Okay. Chris was with her husband and flew on a trip sitting behind someone who had an incessant cough. And within 2 days, her husband developed a fever, a sinus, an ear infection, and a dry cough. He was sick for 3 weeks. And then she developed the cough, fatigue, and dizziness for about 3 weeks. And they're wondering if they had COVID-19. Oh, let's see, although they weren't ill.
It's possible. I mean, the problem is, again, because we don't live in a country where we can easily get tested, it's very possible. Now, what they may want to do is let their primary care doctor know so that down the stretch, depending on where they live, the doctors may be interested in getting antibody titers on them. So I have a friend, for example, who did 2 very high-risk procedures on patients who then later turned out to be COVID positive. He didn't really have symptoms. In fact, his COVID test came back negative. But because he had such high-risk exposures, they tested him for antibodies this week, and I don't know the results of that. But the benefit to that wouldn't necessarily be to the people who are asking the question. But if they have antibodies, they have the potential of contributing by maybe donating their plasma. So those are pretty compelling disease processes, although 3 weeks is kind of a long time. Typically people who are going to have a minor illness are going to have it for 5 to 10 days. And the sinus infection kind of argues against it. And remember, so we are still in flu season. So a friend of mine's child got very, very sick and she went and got tested and it wasn't COVID-19, it was influenza A. So we don't know for sure what she had. There's no way to know that, you know, by looking retrospectively, but she should contact her primary care doctor to notify them to see if at some point in the future they want to test them for antibodies.
Excellent, thank you. What is the efficacy of the chloroquine in COVID?
So that's what we were talking about earlier. Both hydroxychloroquine and chloroquine, we don't know at this point. There are very, very small studies that are not robust that say maybe there's some efficacy. It sometimes works in patients. It sometimes doesn't work in patients. So at this time, it makes no sense to recommend them because these are drugs that have very serious side effects. So at this point, I would say we don't know the answer to that, but so far what we're seeing is there's no guarantee with it. It's not a guaranteed efficacious treatment.
Okay. And his next question is, should vegans donate plasma to help?
Well, so again, the benefit of plasma is if you have a known COVID exposure and you have developed antibodies to COVID, okay, right? Now, I will say there are going to be global blood shortages, right? The more often you're in the ICU. So when we give people transfusions, if you recall, I mentioned that blood transfusions can actually trigger ARDS, which is why when someone's in an ICU, we will let people get very anemic before we will give them blood. We know that we'll let people drop down to hemoglobins of 7 unless they're having active cardiac ischemia, in which case we keep them at 10. But 7 is like half your normal blood amount, right? But we know that the risks to giving people blood in that situation outweigh the benefits of giving blood in that situation. However, when you're in an ICU, you're getting blood draws like four times a day. So there's actually something called anemia of the ICU, where you're actually becoming anemic because we're checking your blood so often. So we do need blood for patients who are critically ill anytime there's a pandemic or any sort of severe healthcare crisis. So donating, like going to the Red Cross and donating blood if you're a candidate is always a good thing because the groups can use them. One of the biggest complications of ECMO is bleeding. The first patient I ever put on ECMO when I was doing lung transplant out in Phoenix bled so much, we cleared out the state of blood products. And we were flying in blood products from Colorado. So blood products are necessary. So the plasma itself, I wouldn't say helps anything. And from the vegan perspective, your blood is probably healthier. Like it's probably gonna fight cancer better than someone who's eating meat. But in this case, whether you're vegan or not is the less important thing than just donating the blood so that people in the ICU who need blood can get blood. And remember, people are still having heart attacks. People are still having bypass surgery. We've shut down most elective procedures, but having bypass surgery is not an elective procedure. So people still do need blood for surgeries.
Okay. Would you recommend breathing exercises for people with SARS-CoV or ARDS, or would that put extra strain on their lungs?
By the time you have ARDS, you're not going to be able to do that. You're going to be breathing 30, 40 times. I mean, you're going to be uncomfortable. So breathing exercises aren't going to necessarily help. There is something I didn't talk about when we talked about misinformation. There was some bizarre thing going around that like, if you hold your breath for 10 seconds, it means you don't have ARDS. That is meaningless nonsense. Oh. So I can take your entire lung out for cancer and you can still run marathons if your other lung is good. Okay. Alternatively, you can have mild pulmonary fibrosis and not be able to walk 50 feet without requiring oxygen. So that's just not how lung physiology works. You can hold your breath and still have severe lung disease. A person with COPD can hold their breath and still have severe end-stage COPD. So that is not a good gauge of really anything.
Wow. Okay. I had heard that. Is there anything someone can do who thinks they might have or might be developing ARDS to slow it down or stop it from worsening?
So again, we don't have evidence of, once the process starts, we just don't know enough about how to prevent progression other than the things that we're talking about. So in the olden days, we would ventilate people at certain tidal volumes. We would put a certain amount of volume into their lung. And we've since learned that that's a terrible thing to do. It causes barotrauma, it causes more inflammation, it worsens the process. We don't do that anymore. So I don't want people to start panicking and going, oh my God, ARDS is terrible, I have ARDS. I promise you, you know if you have ARDS. You're already in the ER or admitted to the hospital if you have ARDS. The things that you can do to prevent ARDS, the tangible things are watch your alcohol intake. If you're smoking, stop smoking. If you are obese, we do know, again, the studies are mixed. Some studies suggest that there's an increased risk of poorer outcomes. Some studies say there's not really much difference, that being obese is not a risk factor. The largest thing that you can do, honestly, to prevent this from happening is be safe, right? Stay at home, don't get COVID. But also, you know, if you're smoking, and that includes pot, if you're doing drugs, and, you know, a drug overdose is a risk factor, right? If you're a drinker who develops pancreatitis, that's a risk factor. If you get into a car accident, that's a risk factor. So wear your seatbelt, drive safely, right? Like reduce the risks that you can develop ARDS. That's really the best thing that you can do. But I don't want people, I feel bad now because I'm worried that people are going, oh my God, they're just gonna live in fear of ARDS. I don't want people to live in fear of ARDS. I want them to understand how severe it is and know that the best thing that you can do is stay at home.
Great, thank you. If someone is having chills and a cough, but not a fever, could they have COVID?
They can, but it's less likely. We know from data that fever is the most common thing. And while I'm on the subject, there's no such thing as a fever for me. A fever is a fever, right? 38 degrees Celsius is a fever, 100.4 degrees. So I often have patients go, no, doc, 99.8 is a fever for me. That's not a fever.
Oh.
That just, we don't consider that a fever. Like you may feel bad at 99.8 and that makes sense because we're not supposed to be at 99.8, but that is not a fever. The exception to that is if you're immunocompromised. So in the lung transplant world, we have a little bit of a lower bar that will consider someone febrile.
Okay. And Gail says, thank you so much for sharing, and blessings and health to you. Are there any precautions that an expectant mother should take during childbirth? Her due date is later this month. This question applies to both the mother in the hospital during childbirth and infant after birth. Thank you.
So I'll be honest with you, I do not do OBGYN or pediatrics. So the best person to address that is going to be your obstetrician. And I promise you, it doesn't matter what field of medicine you're in, doctors are being counseled on this. So obstetricians have plans in place. Some of them are really, you know, sad plans in the sense that, like, we know, for example, that many people are saying that spouses cannot be in the room during deliveries, right? To minimize the number of people that are in a room being affected. The standard precautions that you're already taking are going to be important, but I would check with your obstetrician and just say, what are the plans in place at wherever it is that you are planning on delivering, whatever hospital that is, or whatever the case may be. Talk to them and say, what plans have you implemented? Because every hospital has a plan at this point for everything.
Okay. And I have a question about people with asthma. Can you speak to that?
There is a suggestion that having asthma, or any lung disease, COPD, anything like that, does increase risk, chronic lung disease. So the main thing with asthma is making sure your asthma is under control, right? And so what are the things that we do when we talk about asthma? Making sure you're taking your medicines properly. In the 18 years I've been doing this, I've met 2 people that use their inhalers correctly. So make sure you know how to use your inhalers, okay? You can go to the CDC website, or you can Google videos on how to use your inhalers properly, and the NIH has some great videos on that as well. So that's an important thing. Make sure you're taking your medicines appropriately, but make sure you're also controlling the comorbid risk factors. So make sure your sinus is under control, make sure that your reflux is under good control, make sure that you have a regular pulmonologist. So what I always tell people is, even if you have very minor, mild asthma, you don't really have a lot of flares, you don't really require a lot of medicines, it's not unreasonable to check in with a lung doctor once a year. I wouldn't do it now, but if you have not seen a lung doctor, it's not unreasonable to go once a year to check in with a lung doctor. Other than that, all the routine things that everybody should be doing, you should be doing, and you should be extra diligent about them. And if you're smoking, quit smoking.
Right. Okay, I think I have, do any of my panelists see any other questions I have missed?
I would like to just, oh, okay.
In the open. So one is, if you're a healthcare worker with a child who has asthma, would you consider the risk to exposure to COVID-19 too great and risky for your child?
That's such a personal question. There's no way for me to answer that, right? Because I don't know I don't know what type of health worker this person is. I don't know what their exposure risk is. I don't know what their, for lack of a better term, personal sense of risk is. So personally, I currently, I've taken a little bit of a break from ICU work because I was very burnt out from it. ICU workers have some of the highest rates of burnout of any physicians. I had planned on coming back this summer, and I volunteered to go back. So I'm going back now because I feel compelled to do that. This is my area of expertise, and my colleagues can use my help. But I also understand that I have colleagues who are telling me that I'm crazy for doing that, because I can easily sit out the pandemic and just continue to do outpatient work, but that's such a personal decision. Any other questions? Sorry, I know that wasn't very helpful, but.
No, that's fine. The last one I think is, can I get rescue inhaler OTC, over the counter?
Most places you cannot do that. It used to be that you could get things like, I want to say it was like this is like before I was a physician, but I feel like Primatene Mist and those kinds of things were available. Right. Most of the time you do need a prescription, but most physicians are now aware, like, they don't want you coming in just to get a prescription. I would contact your doctor and say, hey, I'm running out of my rescue inhaler. And they should just be able to prescribe it to you. And many insurance companies are saying, we'll give you a 20-day supply. because we know that you're sort of hunkered down. Now, I personally recommend most insurance companies, you get a cheaper deal if you do the 90-day, right? And always ask for the generic, because that's going to be cheaper. But yes, I mean, if you are somebody who needs a rescue inhaler, you always need to keep a rescue inhaler. Nothing drives me more crazy than when my patients come in and I ask them where their inhaler is and they say it's in the truck or it's at home. Don't go to your lung doctor without your inhalers.
Right.
Hey, I see one more
Awesome.
question, Dr. Rao.
Yes, go
And
ahead.
that is, what do you think COVID-19 will mean to us in 2 years? That's from Ray.
So philosophically, that's a really good question. I mean, I don't know. My hope is that people wake up and realize that we have the power to stop 75% of all pandemics by just not being mean to animals at all levels. I think what a lot of people don't, I mean, we're so focused on COVID-19, but we don't have to focus on COVID-19. You can look at Ebola, you can look at HIV, you can look at swine flu, you can look at avian flu, but you don't even have to look at those things. You can look at every E. coli outbreak, every salmonella outbreak. You can look at the epidemics of heart disease and type 2 diabetes and stroke. There are plenty of personal reasons. Now, I don't really necessarily consider those vegan reasons because that's not really about the health of the animals, that's about our health. But, you know, I mean, there are karmic reasons if you're a spiritual person to be kind to others. So for the same reason that I am going to vote, you know, to make sure that everyone has universal health care, even though I will always have health care and it doesn't necessarily affect me. I want my fellow human persons to be protected. I want my fellow animals to, you know, non-human persons to be protected. So I hope in 2 years, we're gonna look back at this and say, this was the event that got people to wise up and say, we don't have the luxury of, you know, meat, like, so this is a dumb thing, but I'm an abolitionist vegan at heart, so I don't endorse things like meat-free Mondays, but I also don't endorse heroin-free Mondays. I think if you're gonna stop, stop. How you choose to do that is up to you, but my job as a physician is to tell you what you need to hear, not what you wanna hear. So my thing is, you know, I hope that in 2 years that we have woken up and said, we have destroyed the planet and we have very little time to recover this, not just from a pandemic standpoint, but from a climate change standpoint. I mean, we're getting, you know, the media refuses to cover pandemics and refuses to cover climate change in a meaningful way. And if I have to read one more article that says, cut back on your meat to help the environment, and I'm just like, if I as a doctor said to a person, you know what, stop smoking 2 packs a day, just go to smoking 5 cigarettes a day, I should be fired. Right? I mean, like, it just is crazy. Now, look, I'm not saying that when a patient comes to me and says, doc, I don't smoke 2 packs a day anymore, I smoke 5 cigarettes a day, I'm happy for them, but I'm still going to get on them about those last 5 cigarettes, right? Because we know there's no safe amount of animal product to ingest for us, for the planet, for the animals. So, and it's not just that, right? I mean, it's the use of animals in animal testing and the, you know, it's people, I mean, we could talk about this forever, right? I mean, animal agriculture is one of the leading causes of antibiotic resistance. The people who work in slaughterhouses have 5 times the rate of PTSD and 5 times the rate of domestic violence. And, you know, they have horrible amputations and none of these people have health care. The people who live near CAFOs have dramatically increased rates of respiratory illness and cancer and those kinds of things. And it's a really racist industry, right? It preferentially places these industries in poor communities of color. So, I mean, I tell people this all the time. I really don't see any difference if you're buying animal products now versus buying slave-grown cotton in the 1800s. You're still buying the products of enslavement. So it's very extreme, but, you know, or some people would say that's extreme, but I mean, I see a very clear line between those two things. So I hope that answered your question. It was kind of rambly, but my hope is that in 2 years, we're going to look back on this and the world is going to be a different place. You know, Sailesh, you've shown us those slides of land that comes back within 6 months, right? You know, so I hope we see this as, why are we burning the Amazon and why are we grazing animals and why are people starving when we could just be feeding them grain,
Right. Well, what say, Dr. Naik? I'm thrilled that you are on this program, and I'm
Thanks
so
for having
grateful
me.
to you. So grateful to you for what you're doing and for your service on the front lines. I think this has really changed the conversation about healthcare workers, people who stock our grocery shelves. You know, we see them as people who are taking risks for the benefit of the community now, you know.
And isn't it crazy that, you know, I get praise for being a physician and ER physicians. And listen, the ER physicians are, I fight with ER physicians all the time in my job, and I will not fight with ER physicians ever again. I mean, these guys are heroes, right?
Right.
The risks that they're taking, any stupid thing that they want me to do, I will happily do at this point, right? They are just heroes in this. But it's crazy to me that we're not talking about, a hospital doesn't run without environmental services.
Exactly.
Right?
Yeah. Yeah.
We're going to starve if we don't have people, you know, who are there keeping the grocery stores open. And none of those folks have paid sick leave, and none of those folks have health care, and none of those folks have incomes that are remotely reasonable. And that is offensive.
Right. Absolutely.
Right? So
Absolutely.
it's ridiculous that I can not, if I choose not to, I mean, yeah, it's going to be a pinch for me, but I could choose not to work for the next few months until the pandemic calms down. And it'll be a little bit of a financial hit, but, you know, I have savings because I have, you know, I have had a living wage in order to save up money. So it's ridiculous that we have people that that's not happening to. And these are the people that are essential, right? I mean,
Right.
look, I'm sorry, CEOs are not essential.
This is proving it beyond a doubt.
Right. I mean, so somebody was saying something about how, you know, well, we can't punish CEOs. I'm like, if you're making $30,000 a minute, you're not working. You're literally existing and pocketing money.
Right.
Right? That's not work. So, you know, like we need to spread that. We need to spread that money to the people who are, I mean, I think we've seen that the people who are given the least amount of respect, and this is globally, right? I mean, we've talked about this with Modi and the shutdown in India. It's very easy to say what a great thing he's done, but this is completely ignoring the abject poverty of the people who are going to starve to death. I mean, poor Indians are going to die in the thousands, right? With a 21-day shutdown. And that's not okay. It's not okay that people like Ambani has a 40, I mean, I don't even know how many stories is his house, right? And there are slums right outside. And you know, when I bring up India, let's be clear, we just sanitize it in America. We sanitize our poverty in America.
Mm-hmm. Right. Yeah. No, this is asking us to rethink everything, which is really what we are trying to do in this summit. You know, we're gonna. So I'm going to invite you to come back for the April 18th, so we can have a panel discussion with all the experts. And I'm really, really looking forward to you coming.
Yeah.
Talking.
I'm just going to say one more thing to the gentleman that asked about 2 years from now. So it is my hope that the other lesson that we have learned is how to take care of each other and how to make sure that we place value in our waste management staff and in our landscapers and the undocumented immigrants that are still picking our lettuce and working in slaughterhouses and all of this ridiculous stuff that we're still expecting them to do, so that we can sit at home.
On that note, thank you so much.
Thanks so much.
Dr. Rao, can I read a couple of the comments here that are non-question comments? Just take 1 minute, if I may, because
please.
You've got a real fan club gathering here. Carla says, this is the best presentation ever. Dot says, thank you so much. This was amazing. Carla says, please get Dr. Naik on CNN, Fox, MSNBC, exclamation point. Sarah says,
I'm not sure I want to go on Fox.
Sarah says that was great. Christopher says thank you, Dr. Naik, with lots of exclamation points. And Dot says, I've been following the epidemic since January. I've learned a lot here. And people asking about, is this going to be recorded to be shared later? Couple of things there. It's in the Climate Healers Facebook page. You can share it from there. Later, after the recording processes and everything, it will be on the Climate Healers YouTube channel and on the Climate Healers website. And you can go to the page where the coronahealers.org, and you'll see a link there to click to the replays. This is not a summit that expires. It's not something that you're going to be sold later. All of this is available to distribute as widely as you want to and can distribute it. So please go to those places and please do share, and we'll give you further information about the Dr. Naik fan club in the in the coming days, and lots more here, lots more about just thank you. This is fantastic. Any chance you want to run for president? Yes.
Absolutely not, because I'm not going to lie to people.
Exactly.
Well, that's a new system in which, you know, people.
Right. Well, listen, can I mention just one thing for folks that maybe think of questions later? If you go, there's a local farm animal sanctuary called Farm of the Free. They have a public Facebook page. I was supposed to do a fundraiser event with them where I gave a talk on the benefits of a plant-based diet. Obviously, we're not going to do that. And so what I am doing instead is I'm doing a Q&A on Zoom. You gave me the idea, but what we are really asking is, before you register, please donate some money, and then join us, and feel free to ask any questions that you want to ask. The whole point of this is to get the information out there, but particularly in this case, the sanctuaries are hurting, right? Because no one's able to have volunteer days, or not able to do this stuff. They unfortunately just lost an older donkey as well. So they've got the funeral expenses and all of those things that they need help with. So please do donate, and then please feel free to come on and ask any questions, share it widely as you'd like to. I normally focus my Instagram page on just the scientific evidence for a plant-based diet, but these aren't normal times. So I am posting COVID information there as well. So feel free to check in there as well. It's at _the-veg-doc.
Awesome. Now, before we close, I want to tell people that this is the third interview in a series that's going to go on till April 16th. And so tomorrow we're going to be talking to Dr. Daniel Chong and Dr. Russell Mars about naturopathic solutions to COVID-19, and then the Climate Healers Health Conference. So please join us, please share widely, and I look forward to seeing you all again very, very soon. Thank you.
Thanks.
Thank you.